Hello and welcome to the Talk with Tariro. This week we are continuing with our discussion that we had last week, where we were looking at a research that was done looking at obstetric fistula. And we heard that the research was done in 6 provinces in our country, and it was seen that the problem is quite prevalent. So this week we are privileged to have a medical practitioner who is going to go deep into us, explaining to us the medical aspects of this particular condition. We have on the show Dr. Takura Kanonge. Dr. Kanonge is a gynecologist. Those who know a gynecologist, those are the doctors who help us when we are delivering our babies. So he is indeed the right person to help us understand this condition. If we remember last week when we had Rose on the show, she was explaining it happens when we are delivering babies, and oftentimes we struggle with those. So yeah, now we are going to have the doc really explain to us. Dr. Kanonge, welcome to the talk.
Thank you very much for having me.
Yes. Now we want to hear from you in terms of the medical aspects. Maybe explain to us about this condition that we call obstetric fistula. And I was asking Rose last week to say, is there a Shona word? And she's like, there is nothing. So medically, when I come to you and I don't speak English, how do you explain this to me? Maybe unpack this condition for us.
Maybe if I start by defining it.
Yes.
So an obstetric fistula is an abnormal connection that develops as a result commonly of a complication of delivery or of birth or of childbirth, such that there's an abnormal connection between the vagina and the urinary system. So the system that helps us release urine, or it can be an abnormal connection between the vagina again and the rectum or the anus, which is the system that helps us get rid of stool. So it is a complication that arises from pressure, usually caused by the head of the baby as it comes down in the pelvis. If it gets stuck for hours, then that pressure causes abnormal connection between all these systems. So basically, that is what is called an obstetric fistula. Sadly, we don't have a local name for it, and we tend to find it very difficult to explain to our clients.
Yeah.
Definitely. So in summary, that is what we call an obstetric fistula.
So is there something that I would have done for me to go through that? This is where we are saying, is there something that causes it, or it just happens? You just tend to be unfortunate and then you experience it?
The World Health Organization has actually defined obstetric fistula as a crude marker of quality of health care. Labor is unpredictable.
Yes.
Even a woman who has delivered 5 children before can have a complication such that labor does not go according to the expected progress that we know. So in summary, we are saying it can happen to any woman of childbearing age. However, there are certain groups that are more at risk. So these are the teenagers. So in other words, young girls who fall pregnant are at an increased risk. Disadvantaged communities, for example, those who live far from a hospital, because once labor complicates, they may take days before they get to the hospital.
Yes.
Or it can happen to those who live in some religious sectors,
Yes,
who do not believe in seeking conventional health methods. So these are the ones that are at particular risk. Though I must say as well, any woman is at risk of developing an obstetric fistula. But the 3 groups that I've described are the ones that are at particular risk of developing obstetric fistula.
Maybe if you could, Doc, share with us the cases that you witnessed. You witnessed from your practice when you're delivering, mothers are delivering at your service. How severe is the problem? We heard last week that as a country we are ranking amongst the top when it comes to maternal mortality, and we do know obstetric fistula contributes to maternal mortality. So maybe in terms of statistics, the cases that you witness, how have you dealt with them?
So with the cases that we witness in our routine clinical practice, I would say it's a tip of the iceberg.
Wow.
Like I said, obstetric fistula develops from labor that has become prolonged or something that we call obstructed, meaning that the head and the pelvis do not match. The head is unable to pass through the pelvis. So once, for example, we've then eventually managed to offer a cesarean section and the mom goes home on the third day, they usually do not leak urine. They start leaking on the fourth, fifth day when they're at home. That's why I then said it's a tip of the iceberg, because the symptoms tend to come when they have been discharged from hospital after a prolonged labor. So sadly, we do not have accurate statistics of how big the problem is, but definitely it's bigger than we know.
Yeah.
Sure.
And Doc, when we're looking at it where labor tends to be prolonged, and maybe as someone who's pregnant, I've come to you and you're already seeing that I might have challenges. You suggest maybe cesarean section. We do know there are costs that are associated with that. And as a mother, sometimes I'll just opt to say, no, I'll wait until this happens. How do we address the issue of the costs that are then associated with delivering a baby in a safer way when you have seen that there's a problem, but me as an individual, maybe the resources are actually limited?
I think it's a very difficult problem to tackle. Government has put up free maternity services, but unfortunately, we have the costs involved with buying sanitary wares, cost of food, travel. All that cost has not been put away. So I think the other parameters of healthcare need to be addressed, and it takes the whole community to assist us in achieving better maternity care. But I must also compliment government to say at least it was a start to have maternity services being provided for free.
So when I've delivered and I'm going home, do you then get to maybe tell me that if you see something like this happening, you need to come back and seek services to the mothers, considering we're saying people actually don't know that this condition is what it is?
Certainly. It's our routine, what we call postnatal care. So now in simple terms, it's post-delivery care. Women should be seen on the third day and also on the 10th day. So all women are informed that they should be seen soon after delivery.
I'm sure if we have all the women who are watching us, when doctors tell us that postnatal care is important, it's important that we actually do those follow-up visits back to the doctors, because sometimes we'll sit on this problem and then it's aggravated. We will continue with the discussion after the break. Our discussion continues, and today we are unpacking the medical aspects of obstetric fistula. For any woman who's actually watching a doc, maybe you should then say, is there anything that I need to do as a person to prevent it? Maybe when I'm carrying my pregnancy, to make sure that when I'm delivering, this doesn't happen. Is there anything that I can do, or this is something that just comes from nowhere?
There is indeed simple things that we do.
Yes.
We say the best things in life are free. If a woman chooses to just enter the normal government system or government-run hospital or clinic for care, I think half of the problem is solved. Like I mentioned earlier on, obstetric fistula develops as a result of prolonged obstructed labor. And in our government institutions, we have something called a pathogram, which we use to monitor labor. And we have got set guidelines that tell us that once a woman reaches this time and she has not yet delivered, she needs to be offered an emergency cesarean section. So once a woman delivers or seeks care in the conventional or normal health service run by the Ministry of Health and Child Care, it's half the problem solved. The other half of the problem is now the quality that they get at the health institution.
Yes.
We need us as health professionals now to offer them the correct diagnosis, the correct timely diagnosis and intervention. Because we've also noticed that there are women who have booked their pregnancies. They've done everything correctly. They've gone to the clinic, but by the time that they needed to be referred to the hospital, there's no ambulance. They have to look for their own transport. Once to get to the hospital, they are told, we don't have electricity.
Yeah.
We have to wait for electricity to come back. So these are the other, delays that can contribute to women developing obstetric fistula.
Yes.
But certainly if a woman books early and in a normal clinic run by Ministry of Health and Child Care, I feel we should actually prevent most of the obstetric fistulas.
Definitely one way of us preventing most of the obstetric fistula cases that we witness in our country, we are hearing from the doctor, is for us to seek medical services early, making sure that we register. Doc, on that same line of thought, we have in our communities those that we call Anambuya Nyamkuta, who facilitate home deliveries, and there are quite a number of people who still believe in that a safe delivery actually happens at home. But considering we have this challenge, what would you advise women to then do? Or is there a way that maybe Ministry of Health, you as medical practitioners are working together with Ananyamukuta to make sure this, when they see that there is a potential challenge, at least they rush the patient to the hospital instead of continuing with the delivery, which can lead to these complications?
Certainly, it's a very important area that we should not neglect. Wanambuya Nyamkuta, these are people who have been sort of trained over generational skills, and it tends to lose continued medical education, such that skill timing might be lost as generations pass. So it is a service that we are slowly trying to discourage. But we understand that there are some communities that believe strongly in them. Therefore, there should be a way somehow of integrating them into the system. For example, teaching them how to use the patogram, giving them just crude timelines. For example, in our training, we always say the sun should not rise and set on a woman who's in labor. So generally, it gives you a crude, idea to say a woman should not be in labor for 12 hours. Once you reach 12-hour mark, be worried. So these are some of the little interventions that we might try to hammer in these, traditional practitioners to sort of then maintain safe health limits.
So as a person, are there any signs and symptoms, or it just happens when I'm about to deliver, that I would say maybe I should be worried? Can I opt for maybe that optional cesarean where I can actually just tell my gyna, I'm coming to you and I'm saying, Doc, I think I just want to opt for a cesarean so that I protect myself from this?
So, like I mentioned earlier, obstetric fistulas, they commonly, more than 90% of them, they occur as a result of prolonged labor. So if a woman is in labor for 4 hours and then she gets a cesarean section, we have never seen an obstetric fistula happen because of that. So in other words, there's no way of predicting. Although there are some parameters, like a young mom who is less than 18, who is less than 20, their pelvis is still small. If a baby is too big, and that can be estimated by clinical examination and or by an ultrasound scan, we can opt for a cesarean section before labor. But like I said earlier, what's the major problem here is not labor, but instead it's prolonged labor. Once a woman goes into labor, they should follow specific timelines. If those timelines are not followed, you are then at an increased risk of developing a fistula. Let me also then say at the same time that rarely you can also have a fistula occur because of intervention. By this I mean, if a baby gets stuck, we can pull the baby using something called a vacuum. That rarely can lead to a fistula as a medical complication.
Uh-huh.
Even the cesarean section, rarely you can perform a difficult cesarean section, which may in itself cause a fistula, but this is very rare. And it has not contributed significantly to the number of women with fistula that we treat.
And now, when we are looking at the treatment side, what is available for me as somebody who is actually having this condition?
So the Ministry of Health and Child Care, with its partners, UNFPA and other partners, they have come up with obstetric fistula camps, where we have mentor surgeons or specialist surgeons who come to actually train us as doctors to offer obstetric fistula surgery to women who are affected by fistula. These are ideally supposed to be done once every quarter. Sure.
We will continue with the discussion after the break. Is treatment only through surgery? We will ask more from the doctor so that we have that appreciation. Join us after the break. Welcome back. Our discussion continues. So, Doc, before we went for the break, we were talking about the surgery that happens as a corrective measure. Is there any other way of maybe treating it without me going through the knife?
Sadly, once a fistula develops, there is no other way of correcting it. Though there are some women who develop very small fistula, such that as healing occurs, they close spontaneously on their own. But these are very few cases. But the main treatment for obstetric fistula is surgery. But remember, the illness is not just the leaking of either stool or urine. It's the psychology, loss of income, loss of socialization with family. All that is also treatment. We should not just treat the physical disease, we should treat the whole person. Sure.
So, Doc, when the urine or the feces are just coming out, it's anywhere and everywhere I am, which means maybe half the time I need to be in bed. What really will be happening?
Maybe let me try to give an example. We have got our tap, which we open to get water. Imagine a leak that happens just behind the tap. You can't control it. As long as you've got pressure in the pipeline, water is going to be leaking. So an obstetric fistula affects the areas which helps us to be continent. For example, we have the anal sphincter, which helps us to increase pressure so that we stop stool from coming out until it's socially appropriate for stool to come out. We also have the urinary sphincter, which also is damaged, and hence you are unable to control urine. So yes, unfortunately, most of these women will leak either stool or urine, or both, as a complication of delivery.
And in the whole scheme of things, when all this is then happening, when does maternal mortality then come in here?
That's a very good question. So remember, when a woman is having prolonged labor, it's not only the pressure that's happening. The membranes in Shona, what we call shupa, would have ruptured. And that's a source of infection. So women who have had prolonged labor tend to have infection in the uterus. They tend to have infection that goes up even beyond the uterus into the pelvis, such that they end up with what we call puerperal sepsis. They'll end up with what we call pelvic abscess. In Shona, they call it mortar. All this then contributes to dying. Women who also have prolonged labor, once the baby has now come out, they're at an increased risk of bleeding. We call it postpartum hemorrhage. These are the things that will acutely or in the short space of time cause death. They also can have nerve compression, which then tend to affect their mobility. They're unable to walk, and then they develop clots which can move into the chest and cause incidents of acute chest pain called pulmonary embolism, and they can also die from that. So these are the things that are not, the fistula itself, but they are directly related because they all come from the same problem, which is prolonged obstructed labor.
And we know, Doc, we are in a period where we are grappling with COVID-19 in our country. How has it affected the delivery of health services, particularly with women wanting to seek prenatal care, postnatal care as well?
So it's a very valid question, very important one. We have noticed that the numbers of women who are coming to seek help, they've actually reduced. They've come down significantly because they believe that, the hospitals are closed. Only those who are very ill should come to the hospital.
Yes.
And to some extent, there have also been some maybe professionals who have also taken advantage of this, and they have somehow become unavailable, particularly the primary health sector, where these are the first contacts. We've had many women who just walk into the main central hospital, and then you ask them, why have you just come straight here? They tell you, the clinic is closed. We could not get service. So COVID-19 has really affected provision of essential health service.
Yes.
However, it has also worsened in the fact that we have been unable to offer fistula surgery for more than a year now. Because remember, we need specialized surgeons to come and train us and help us. And these have not been able to come because of the COVID-19 pandemic. And hence our waiting list has grown so big. And we know that women are suffering in silence with no hope in the near future for getting service.
And overall, when we are looking at the country's health systems, are they ready to deal with these cases timelessly, or we are overstretched?
Excuse me. We might have we might have our own challenges, but we have people who are waiting and willing to offer services. I, for one, we've got many gynecologists in the country who are willing and who are itching to be trained to offer these services. Women who have obstetric fistula, they tend to have prolonged stay after the surgery. And Shinoy Hospital and Mashoko Hospital are designated hospitals that are prepared to take care of such women.
So, Doc, I am in Gutu there, and the fistula camps, I understand, did you say two, or they are spread out? Do I have to travel from Gutu to come to this one here when I'm already in that prolonged labor? What then happens?
So with an obstetric fistula, once it develops, sadly, we have to wait for 3 months for tissues or for cells to heal before we can offer surgery. So most women who develop a fistula, we have to wait for a minimum of 3 months before we can offer them corrective surgery.
Okay, all right. I'm sure that's key for us to get to understand. Once it happens, surgery will only come to you after 3 months. What are your final parting messages to us as a nation? In terms of our timeless response, action, when I'm saying that maybe I'm facing a health challenge, particularly to women who are actually pregnant?
My words would be, obstetric fistula is real, it's there, and women are suffering in silence. Let's make the noise, let's shout, and at the same time, let's accommodate them so that they feel at home. Despite their challenges. We are here for you.
Yes, indeed. Pleasing to hear the doctor saying, we are here for you. Let us not suffer in silence. You might not be pregnant, but the doctor is saying this problem is there in our communities. Let's make the noise to make sure that every woman who is supposed to access that sexual reproductive health service accesses it. Until next week, it's goodbye.